As you know, hand is a very important part of our body. There are a lot of functions which we perform by our hands. For example, pinch, grasp, the tactile functions of our finger is actually help us to actually sense a lot of things which we can normally we can do. It can help in our activities of daily living. As we're discussing the deformities of hand, and problems with the hand can be very much problematic, and especially with the patients, especially if they develop problems such as Dupuytren's contracture. Now, Dupuytren's contracture is a benign proliferative disorder of usually facial nodules. But there are structures which are present in our hand. What happens is during the 5th to 7th decade of life, there is actually a increased proliferation of myofibroblasts, especially which is more common in the males. Normally, there is 2:1 ratio. That is, the Dupuytren's contracture formation is twice as much as common in males as compared to females. Usually, there is always associated history such as maybe previous trauma, radiotherapy, or certain associated disorders such as diabetes mellitus, alcoholism, or even this has been seen in patients with anti-epileptic medications as well. Usually the most common area is actually the little finger. That is most commonly it is actually the ring finger. Ring finger is the most common structure which is involved. Then comes after that in terms of incidence is the little finger. Then involves the middle, and lastly, rarely but yes, it can involve the index or even the thumb as well. But usually the most commonly it is always the involvement of the ring finger, as you can appreciate it over here. And this is the distal palmar crease is actually the most commonly involved region along with the involvement of the ring finger. And usually what happens is there are actually different bands which are present in our body. For example, there is a pretendinous band, spiral band, as well as other bands which are although normally present, but their excessive proliferation leads to kind of a formation of pathological bands which causes these kind of a contractures of the palmar crease. And when these contractures develop, this leads to flexion contracture at the proximal interphalangeal and metacarpophalangeal joint. Now usually this is always almost 77% chances, 70% of the patients there is always associated with the contracture of the proximal interphalangeal joint. This is mainly divided into 3 types, or we can call it the 3 stages of the Dupuytren's contracture. Mainly it is initially the proliferative stage in which there is excessive proliferation of myofibroblast. Then is involutional stage in which the myofibroblasts disappear, but the network of myofibroblast with the dense collagen type 3 remains. And then there's a residual stage in which although the fibroblast has also actually disappeared, but this collagen forms a thick scar which can mimic or present like this despite even the residual stage, or it can involve like this, which is maybe associated with proximal interphalangeal joint contractures, as I just told you. Now, although it's rare, but they can involve the index finger as well as the thumb, and when they involve the thumb web space, this usually can present with the gross limitation of the movements with the thumb, especially the flexion, extension with adduction and abduction. Or second most common area is always the little finger after the ring finger, and usually the most commonly involvement is of the ring and the little finger, and little finger contractures can be very problematic as the grip of the hand is actually reduced, especially for the briefcase grip, in which something has to be held in the hand by involving mainly the metacarpophalangeal joint of the ring and the little finger. Now coming to the clinical features, what does the Dupuytren's contracture has is problems which may be associated with the Dupuytren's contracture. The patient may present with, first and foremost, is always nodular thickening. Usually that is something which is very easily or clearly evident that there is definitely some thickening or contracture formation in the palm. Second is pain. Usually it can be painless as well, but most commonly it is always associated with pain and painful thickening and contractures of the proximal interphalangeal joint. Then this may be associated with certain other diseases, as it is actually the myofibroblast of the body which become proliferating and there is associated with an autosomal dominant inheritance pattern. Therefore, there is always actually the proliferation and thickening of other fascias as well. For example, this may be associated with thickening of the on the extensor side of the knuckles, forming Giroud's pads, also called as knuckle pads. Then there may be associated with increased thickening of the plantar fascia. As you can appreciate in this diagram, this is called as Lederer's nodules or Lederer's nodule formation in the foot. There may be thickening of the basically inguinal region as well, which may lead to Peyronie's disease, and especially the fascia of the penile fascia actually becomes quite thickened and leading to problems associated with the urogenital structures as well. Now, when patient presents with this problem, what may be other problems which may be associated with the Dupuytren's contracture? Then there are certain differences which we need to keep in mind. For example, there may be associated with skin contractures, which may be post radiotherapy or post injection or something which may be associated with any other autoimmune disease as well, which may be secondary to some form of a trauma or laceration which occurred previously. There may be associated with tendon contractures. We need to get a careful history as well. Usually this is tendon contractures is associated with either previous trauma or some form of a surgery as well. And finger deformity usually changes with the wrist position, because this is which is important. When we are flexing or extensing, causing the extension or flexion at the wrist joint, usually extension causes flexion of the fingers and flexion causes extension or straightening of the fingers. If this is happening, then most likely this is actually the tendon pathology due to tendon tightness. Or then may be associated with PIP contractures, which may not be due to the Dupuytren's contracture. There may be post-traumatic, there may be associated with previous fracture of the proximal interphalangeal joint, which may have malunited and leading to some form of a contracture. So you must rule out the history of clinodactyly, that is the bending of finger, which is usually present in the pediatric age group. Now, if we have diagnosed it as a Dupuytren's contracture, first and foremost is that you need to tell the patients about the possible course of the disease, and especially the foremost, more importantly, is that there is always a very high chance of recurrence with many of the treatments. Treatment may include like radiotherapy, although this is not the first line treatment. They usually associated with this is a treatment associated with recurrence. The most commonly could be percutaneous needle fasciotomy. Now, if there is only isolated thick nodule, which usually is present in the distal palmar crease over here in the ring or the middle finger, and it's quite limited disease, then percutaneous nasal fasciotomy can be done, and this nodule can be broken by use of a needle, and but this way always has associated high recurrence rate. Other options which include is actually collagenase injection. There's a bacteria called as Clostridium histolyticum, which can release anti-collagenase injection, and when this is actually injected over here, this can cause the lysis of collagen type 3. As you know that in the pathogenesis, there is actually first proliferation of myofibroblast, then there is collagen type 3 which is laid down as well, and then there is a lacy network of myofibroblast and collagen which is actually formed. Once proliferative stage is over, this leads to involutional stage, which is in which the myofibroblasts disappear, but this lacy network of collagen is actually remains along with the fibroblast. Once the residual stage is there, that only contains actually thick collagen type 3 and scar tissue, which can be easily lysed by use of this injection. Then there are surgical options as well, especially which may include surgical fasciectomy. There may be a partial, then complete surgical fasciectomy, then there is subtotal or total. Different options are available. Then it may include that skin grafting as well. Sometimes even the dermatofasciectomy may be performed as well. Even the skin has to be removed to cure the patient of the problem, but then that skin has to be grafted. You cannot leave it as such, otherwise that will recurrence. So therefore these zigzag incisions are actually given to stretch it out, and the contracted tissue is actually removed, and the skin grafting can be done like this. Then there are salvage procedures as well. Now, what are salvage procedures? What happens is if there is recurrence, This may be lead to some form of a procedure such as complete removal or total fasciectomy and dermatofasciectomy. And then to avoid again recurrence after this salvage procedure as well, we may require an orthodesis as well at the proximal interphalangeal joint, so that even if the skin proliferation does occur, the bone is orthodesed and there will be no chance of recurrence of a contracture, especially at the proximal interphalangeal joint. Now we're moving on to another disease called as Volkmann ischemic contractures. As you know, that forearm trauma is quite common, and the forearm contains two bones, that is the radius and the ulna. And if for any reason post-traumatic or for a like the bell problem mistreated iatrogenic, pressure is actually increased in the forearm, this can lead to compartment syndrome. Usually the first and foremost signs are actually the 6 P's of the compartment syndrome, that is the pain out of proportion, paresthesias, then this may be a pain on the passive stretch, paresthesias, pulselessness, pale limb, which may be a lateral sign, and usually when it pale limb and pulseless limb appears, this usually already the contracture or the compartment syndrome has quite progressed. That means, therefore, we need to rule it out whether there is associated with compartment syndrome or not. And usually the first and foremost two things which we need to rule out, that is there a pain out of proportion to the patient, and is there pain on the passive movements of the hand. If these two are present, we must measure the compartment pressure. If compartment pressure is actually, there's a term called as delta P, that is the compartment pressure is within or less than 30 millimeter of mercury as compared to the mean arterial pressure, therefore then fasciotomy must be performed. Otherwise, if it remains unchecked, or if the cast was applied and patient somehow beared the pain or somehow was unable to come, or if this was treated by bone setters, usually what we see is resulting in this kind of a problem, in which the prolonged compartment syndrome leads to first compromise and ischemia, eventually muscle necrosis, and then this leads to a development of ischemic contractures, which is called as Volkmann ischemic contractures. Like this was usually associated with pronated arm or forearm, flexion at the wrist joint, adduction of the thumb, and with flexion contractures of the finger. And later on, initially, once it develops, actually it's very difficult to treat, but we can treat it early by stopping the development of compartment syndrome. But once it develops, then it depends what kind of a pathology it is and how much treatment is needed. The treatment can be started initially with the passive stretch exercises so that the contractures are relieved. Then later on, maybe tendons may need to be transposed, or may need to be a kind of a transferred to different origin, depending upon which compartment was involved, whether it was flexor, extensor compartment. And once tendon transfer can actually partially correct this deformity. Now coming on to another problem called as the mallet finger. Actually what happens is, you see, this is the kind of an injury which may predispose a person to a mallet finger. What is mallet finger is, as you know, there are two flexors, mainly the flexor digitorum superficialis or FDS, and then there is flexor digitorum profundus or FDP. Now FDS attaches over the base of the middle phalanx, and it is actually acting on the proximal interphalangeal joint only, while FDP attaches on the base of the distal phalanx and acts on both the proximal as well as the distal interphalangeal joint. For any reason, for example due to trauma or a knife laceration or something goes wrong, and the tendon of the FDP is intact, but the tendon, extensor tendon, which is attaching on the distal interphalangeal joint. Now extensor tendon attaches by another formula, that is there are actually one slip which attaches, central slip attaches on the proximal interphalangeal joint and the base of the middle phalanx like FDS, and then there are two slips which are actually attaching it on the distal interphalangeal joint. Now if for any reason these slips get cut, this would result in an unopposed pull of FTP, and FTP will pull the distal phalanx into flexion. This may eventually lead to mallet finger kind of a situation. Now, as I told you, this is how it happens. The extensor tendon is coming in, and the central slip is attaching it over here. The lateral slips actually join and attach it on the distal interphalangeal joint. If this is cut for any reason, this will lead to an unopposed pull of FTP, which is attaching it over here and would make the distal phalanx go into flexion, as you can see it over here, because now the FTP pull is actually unopposed. So how to diagnose it? Usually there is always associated history of trauma, and maybe isolated ligamentous injury, and X-ray may be normal as well, but mostly it is always associated with a distal phalanx fracture as well, as you can appreciate it over here. Now this is showing probably a mallet finger with an isolated ligamentous injury in which the only extensor tendons are ruptured and the phalanx is going into flexion. But this also shows that there is not only a mallet finger associated with the fracture of the this dorsal aspect of the distal interphalangeal joint or the distal phalanx. Now treatment could be if it is an acute injury or a chronic injury. Acute injury can be treated by this form of an extension splint, in which the distal phalanx is actually kept in a hyperextension for 6 weeks, and we allow it to heal. If it is associated with undisplaced fracture, simply isolated extensor tendon injuries or undisplaced fracture with extensor injuries can easily be treated with a splint. But if there is extensor tendon injury along with the displaced fracture, then we need, probably the splint will not be enough, then we need some other form of a treatment, and usually it can be in form of that is, we first repair the tendon and then we apply the splint for 4 to 6 weeks. Now if it's a chronic injury, for example this was a missed injury and a patient presents after 2 to 3 weeks, then first we need to do is we can go for surgery straight away and go for extensor tendon repair or a graft, or so that then as one slip can be actually used as a graft and attached to the other slip, and extension mechanism, tendon mechanism can be restored. Coming to another rare but a very important topic, that is the ruptured EPL or extensor pollicis longus. Now EPL is actually attached over the distal phalanx or the of the thumb, and if it usually results, its rupture actually results due to the forceful flexion at the thumb when a person, especially during a fight mechanism, person is trying to hold somebody. This is forceful flexion of the thumb can sometimes lead to rupture of the EPL. Or sometimes what happens is that there may be associated with problems of the EPL itself. For example, in case of rheumatoid arthritis, our patients, the tendons may not be strong enough, they may have deteriorated over time or degenerated over time. As a result, even this may lead to rupture of the EPL. Could be very common. Another common cause of the rupture of EPL is actually usually after the POP casting for the distal radius fracture. Due to this, it is commonly seen as with this kind of situation with distal radius fracture, as there is always associated with a rupture of the EPL, and usually patients, those who've been given the POP, after 4 to 6 weeks they come and say that they are unable to extend their thumb because after this injury, and this is usually associated with ruptured EPL. If it's acute, we can apply some form of splint, and if especially the cause is traumatic. But if there is a pathological cause like associated with degenerated EPL or associated with the problems after the POP casting for the radius fracture, then probably EPL reconstruction is required, and usually extensor pollicis indicis proprius is actually used to reconstruct extensor pollicis longus, as you can see it over here. Now coming to another problem of the metacarpals and phalanges is boutonnière deformity. As I just told you that on the extensor side there is an extensor hood and a central tendon attaches it on the middle phalanx and like this, and if the central slip attaches over here, and that there are 2 lateral slips which continue forward and attach it on the distal phalanx. If for any reason this extensor slip is torn, this could be torn, leads to a form of a boutonnière deformity, and that is that there will be FTS attached over here and FTP would be attached over here. Although FTP pull will be opposed by the lateral bands, but FTS pull will not be opposed by the central band of the extensor tendon at the proximal interphalangeal joint. Now this results in actually hyperflexion of the PAP with some form of extension at the distal phalanx. This is classically formation of the boutonnière deformity. Like if you see it over here, this is the hyperflexion or increased flexion of the proximal interphalangeal joint. And why this has happened? Because the central band has slipped down. As a result, the lateral bands have gone down and they have actually now acting, initially they were acting as extensors, now they are acting as the flexors. And there's also pull of FDP as well. So there is hyperflexion at the proximal interphalangeal joint and middle phalanx going into sort of a hyperflexion, which actually the FTS and FDP and extensors lateral bands are exerting equal pull. So this is actually straightening of it, the distal phalanx, but it appears as if the hyperflexion has caused some form of extension at the distal interphalangeal joint, leading to a boutonnière deformity. And usually how to treat this boutonnière deformity? The treatment usually involves the repair of the extensor band, or what we can do is we can rule whatever this central slip can be repaired or reconstructed so that the patient can be relieved of this the boutonnière deformity. Now coming to the swan-neck deformity. Swan-neck deformity is also seen in the PAP, and it's slightly different as compared to the boutonnière and mallet finger. Usually this is caused due to the PAP extensors overreact. There is actually increased extensors contracture, and this results in actually extension at the PAP or interphalangeal joint. An intrinsic muscle spasm or contracture, which may be present, for example, due to multiple, this may be neurological causes or other causes as well. Then PAP flexors, which are actually the FTP and FTS, are inadequate, or for example, this may be due to the palmar plate rupture, or there's a rupture of the FTP, FDS, which is actually resulting in this sort of a problem as well. There, for example, inhibition or division of the flexor superficialis. And if the palmar plate get damaged, as the tendons act by a palmar plate, therefore the flexors actually become useless because now they cannot act on the proximal interphalangeal joint or DIP. Therefore, this usually happens in case of rheumatoid arthritis, dexated joints, or in case of a trauma. And this all causes the swan-neck deformity. So what is basically swan-neck deformity? There is hyperextension at the proximal interphalangeal joint with extension flexion at the distal interphalangeal joint, as well as the flexion at the metacarpophalangeal joint, and this results in the swan-neck deformity. Now coming to the treatment of swan-neck deformity, as you can appreciate it over here, there is hyperextension with flexion as well as a flexion of the metacarpophalangeal joint, producing a classical swan-neck deformity. If it's an acute cause and cause is most likely traumatic, then probably we can go for this kind of a splint in which the flexion, hyperextension or the proximal interphalangeal joint can be reduced back, and splint can be given for a few weeks so that once the fibrosis occurs and healing occurs, this will probably go away. But if the problem is related to something like the underlying cause, rheumatoid arthritis, means the tendons are actually problematic, and then probably the reconstruction of the flexor tendons is usually required to relieve the patient of classical swan-neck deformity. Now coming on to another disease of the fingers, that is the trigger finger or digital tenosynovitis. As it is, the name says, actually a stenosing tenosynovitis, which may leads to trigger finger or finger which is actually catching and locking usually. The patient, first and foremost, this is actually a nodule which thickens, and more common it thickens over the A1 pulley, are at the metacarpophalangeal joint. As you know, that in our body the A1 pulley is in a metacarpophalangeal joint. You have A2 over here, then between A2 and A3 you have C1, and then A3 is the PAP, with A4 and A5 is usually the DIP. Now what happens is, the most commonly it involves actually the metacarpophalangeal joint or A1 pulley, and there is a nodular thickening, and when the tendon glides over it, this is actually results in the catching or locking of a tendon, especially during the flexion or motion of the finger. And this is why when this gliding occurs, this leads to patient complaints of it as if this digit is actually catching something inside over the certain structure. And this is usually, there are different methods to relieve of it as well. The first and foremost, most commonly it involves the A1 pulley. It may be associated with rheumatoid arthritis, diabetes mellitus, or even amyloidosis. And usually the treatment of choice is mostly is actually the injection, which could be in form of a steroid injection. If it is where the trigger finger is, you can inject it over there and relieve the patient of the symptoms, and usually this results in a lysis of it. Or if it relapses or it's recurring again and again, then we can go for a operative treatment, in which is usually associated with operatively you numb the patient's hand and then take out the A1 pulley, which is actually creating the problem, because that is actually when the tendon is gliding past the A1 pulley, it's actually catching at that level. That usually leads to A1 pulley release for the treatment of trigger finger. Now there's another term called as infantile trigger finger. This is usually a rare disease, but this may be present as well, and especially usually the children don't complain of, but this may be especially very common with the thickening of the flexor pollicis longus. And when child try to flex the thumb, this is usually a triggering kind of a sensation which he or she may feel, and there is usually also audible, as well as the audible clicks may be heard by the parents as well. And when parents usually palpate the thumb, they usually complain that there is quite a thickening which is present over here. And as this is a FPL thickening, and which is usually involving the interphalangeal joint of the thumb of the child, and as initially it may be isolated thickening, as the child grows, by 2 years time this may be associated with the interphalangeal joint contractures due to the quite a lot of thickening of the FPL. As you can see it over here, is this is usually associated with quite a thickened FPL. The treatment involves mainly the release of the FPL, and so that the child can be have a normal this trigger finger, and instead of having this problem, child can have a normal thumb and later on can function like a normal adult. Now coming the diseases of the hand is actually it's impossible to actually complete the list without two diseases. One is rheumatoid arthritis, and second is osteoarthritis of the hand. And as I told you, that rheumatoid arthritis, although mainly involves the wrist joint as well as metacarpophalangeal joint, and it has a classical deformities which we developed with the carpal bones and the metacarpophalangeal joints, associated with periarticular erosions and osteopenia, leading to classical kind of a eaten up deformity which is usually visible on the x-rays. And then there is osteoarthritis, which also affects more distal areas, especially the PAP and DIP joints, but usually this results in a formation of osteophytes, reduced joint space, which can be seen on the x-rays, as well as nodes which can be seen in form of Bouchard and Aberdeen nodes on the PAP and DIP respectively. So mainly the rheumatoid arthritis affects the wrist and the metacarpophalangeal joint, although it can affect PAP as well as DIP as well. Usually the early symptoms include, which may be the stiffness and swelling of the fingers, which is very common. The history of the morning stiffness, which may last about more than 1 hour. There is specific swelling because of the carpal bone involvement. There's wrist swelling itself, sometimes is associated with wrist deviation as well. There is carpal tunnel compression, which may lead to a carpal tunnel syndrome, the numbness of the palmar aspect with atrophy of the thenar eminence, as well as sensory loss over the radial 2.5 fingers. There will be finger spindle may become spindle shape as the joints degenerate over time. There may be swollen of the tendon sheaths as well, because there is increased contractures and fibrosis of the hand, leading to swelling and contractures of the tendon, and may eventually present with joint tenderness and crepitus. And this all may be associated with a lot of pain, especially during the movement of the wrist joint and metacarpophalangeal joint. Or there may be joint mobility and grip sense may be diminished as well. Now, classical deformities of the hand actually include, there are certain deformities at the distal radial joint, then the carpal bones, then at the metacarpals, then the fingers. Usually there is slight radial deviation of the wrist joint, and in the radial deviation is such that actually the distal radial going is radial and volar, while carpal bones are going ulnar and slightly dorsal. Then there's ulnar deviation of the fingers, with metacarpals going in the radial direction. If you see, this is the thumb and this is the radial side. Metacarpals are deviating radially, with fingers deviating ulnarly, with the wrist joint, distal radial ulnar joint deviating radially as well. There is maybe associated with swan-neck deformity, that is the hyperextension of the PIP with flexion of the DIP joint. There may be isolated boutonnière, because the tendon may become tethered and degenerated, and usually results in hyperflexion of the PIP and extension of the DIP. This may lead to drop finger or mallet finger, in which there is actually the tendon, lateral slips of the extensor tendon become tethered and eventually degenerate, leading to hyperflexion of the distal interphalangeal joint. And there may be volar dislocation of the metacarpophalangeal joint. Most commonly what involves is the metacarpophalangeal joint. There may be volar dislocation, radial deviation, periarticular osteopenia, erosions, and leading to almost the destruction of the metacarpophalangeal joints. Usually if you see general weakness involves, general features involve weakness. There may be associated rheumatoid nodules which may be present on the hand as well as the elbow and other parts of the body as well. And this is called a Z collapse. And why you call it a Z collapse? Because this results in a zigzag kind of a deformity. The wrist is going radially, then carpal bones are going volarly and different direction, then metacarpals again going radially, and then fingers are going ulnarly. So it actually produces a zigzag kind of a deformity, leading to Z collapse. Now, how to make a diagnosis? If you see it over here, can you see periarticular osteopenia, especially of the metacarpophalangeal joint? This is one form in which the rheumatoid arthritis can present. Eventually, you can see there is actually periarticular osteopenia and erosions in the subchondral bone is actually collapsing over here in the metacarpophalangeal joint. This is another form of presentation, and the rheumatoid arthritis can present with this kind of situation as well, in which the metacarpals are radially deviated, fingers are going ulnarly with almost loss of or destruction of all the metacarpophalangeal joints, with periarticular osteopenia and destruction, and probably this is kind of a classical scenario of a rheumatoid arthritis. Then comes the treatment. Early stage diseases, the first and foremost with rheumatoid arthritis, you need to have a medical therapy. That is the disease modifying anti-rheumatic drugs which can be given. And then we have, for that, we have to look for it that if this is associated with either boutonnière or swan-neck deformity, and there is isolated involvement of the boutonnière swan-neck deformity, then we can go for these type of extensions or flexion, actually splints, in which we can maintain the finger so that it can heal over time. But if it is chronic or if the multiple tendons are involved and there is classical destruction of the joints, then there are different options for established disease, which may include actually, for example, in this, all the tendons are being removed and all the fascia, because it actually leads to quite of contractures surrounding the tendon sheaths, has actually been removed, and so that the tendons can glide easily and the function of the hand gets improved, as you can appreciate it over here as well. And then the fascia is actually being removed from beneath the tendon sheath. Other treatment options for the lead disease include like orthodesis, so that once the joint becomes so destructive that it's not actually possible to salvage it, then we can go for metacarpophalangeal joint excision as well. Then along with the carpometacarpal fusion, that is always required, but usually that is only if the degeneration has progressed to a quite extent. Nowadays more towards actually the replacement of interphalangeal and metacarpophalangeal joint as well. Initially there was attempts to silicone replacement, but now it's been noted that with silicone there are associated a lot of complications, and we are going towards the total actually replacement of the either the wrist joint or the carpal bones as well. Like you can see it over here, the wrist and with the metal plastic implants are actually being utilized so that the movement of the wrist joint can be restored. Now moving on to the osteoarthritis of the hand. As I told you, the hand actually affects mainly the distal and proximal interphalangeal joint. It can affect the distal interphalangeal joint in form of the nodes formation, which is, you can see, is classically called as Aberdeen nodes. And when you see it on X-rays, you can appreciate that the reduced joint space, osteophyte formation in the PIP as well as DIP, as well as the joint destruction and osteophytes, which can be seen right over here as well. Or they can present with swelling over the proximal interphalangeal joint, that is the Bouchard nodes, which can be appreciated in this diagram. Now, if the patient has usually osteoarthritis of the hand, which is usually mostly related to old age, then the treatment options could be mainly, the first and foremost is usually the pharmacotherapy, splintage and physiotherapy. But if that doesn't work, we can go for silicone replacement or even the replacement of the proximal and distal interphalangeal joint, like this, which there were different generations. Initially it was this, now different generations of replacement actually have come, and knuckle replacement is quite getting common. Or even we can go for orthodesis. If it is involving the DIP joint, we can fuse the distal interphalangeal phalanx with the middle phalanx, and so that the patient can have normal restoration of motion at the hand, and patient can get relieved of debilitating pain which may be associated with the osteoarthritis. Other treatments, as I told you, it may be involving the, as can be appreciated over here, as the P and proximal interphalangeal joint, arthroplasty or knuckle replacements can be done. Similarly, silicone replacements, although it is associated with a complication, but it can be done as well. Now coming to the acute infections of the hand, there are different terms such as paronychia, in which there is a nail bed infection, which chronic way involving the different parts of the nail, or phyllon, in which actually the pulp infection mainly, or septic granuloma, which actually forms following a traumatic injury which has got infected over time. Now in acute infection, the patient may present with some form of septic arthritis, in which there is acutely swollen hand or finger or a joint, and which is actually highly painful. Or it may follow an insect bite, in which actually the infection is spread in the dermatofacial planes, leading to increased swelling and pain and decreased range of motion. Or this may be associated especially during the fight bite, that somebody has punched in somebody's face and then that person bites, is usually associated with increased achinella infection, and mainly involves the dorsal side of the metacarpophalangeal joints. Or this may be associated with web space infection. Web space infection is very common in tailors or sewers who actually are working with their hand, and as a result needle gets punctured into the web space and they don't realize it, and eventually once the web space infection develops, this may present with a lot of swelling, and eventually it may resolve with some form of a contracture or decreased range of motion as well. Now treatment involves, acute treatment of the infection was to antibiotics, which could be IV or oral, rest and splintage and elevation, but that is also what's more important is to the drainage. If it is actually the swelling is severe enough, then this may lead to some form of a compartment syndrome. For example, in the case of the distal phalanx or at the distal or proximal interphalangeal joint, and these are the different incisions which can be given depending upon where exactly is the infection, whether it's involving the palm, it's involving the proximal, middle or distal phalanx, so that the abscess, if it is accumulated, has to be drained. And then once we have get rid of the infection, then is the rehabilitation, so that the contractures don't develop and the joints remain supple and patient can carry out his or her activities of daily living. Now, if it's paronychia, it's usually associated with nail bed swelling, and it can present with swelling over here, especially on the dorsal side of the distal interphalangeal joint, and usually it's highly painful. And if it gets unchecked, it may eventually progress to necrosis or gangrene of the whole nail bed. So therefore, usually it needs quite urgent treatment in form of a drainage. There is disease called as Raynaud's disease. It is actually associated with, usually common term is actually cold intolerance. What happens is when the hand is actually exposed to a lot of cold, there's constriction of the arterioles. In the patients with Raynaud's disease, there is extreme constriction of the leading to severe form of ischemia and necrosis and bluishness of the finger, which is actually quite painful. Therefore, there is constricted digital arteries, which actually leads to constricted digital arteries which block the blood to the fingertips and eventually causing mainly the ischemia, which may eventually progress to venous congestion and eventually to necrosis. Now, what is the treatment? As you can see it over here, these are specially called as, the one term is chilblains, and other is actually the these kind of a Raynaud's disease. The Raynaud's disease, usually the most commonly it is actually at the fingertips. Why? Because the digital arteries get constricted, and these are getting the terminal blood supply, eventually leading to a lot of bluish of the fingers, and this is usually precipitated by cold. Therefore, first and foremost, we need to prevent this exacerbation of this phenomena, and especially due to colds. Therefore, we can need to advise this patient gloves, and then there are certain medications such as, well, for example, such as calcium channel blockers, which we need to give. Sympathectomy, antisympathomimetics can be given as well, so that which actually reduce the contracture of the arterioles. And if it all doesn't work out, then we may need to reduce or cut the nerve supply to these arterioles in form of rhizotomy, so that the patient can be relieved of these serious condition called as Raynaud's disease, because this eventually can lead to gangrene and eventually may require some form of distal stump amputation as well. Thank you very much. Keep watching sqadia.com.